All right, are we ready? Okay. Yes, Dan says yes, so we are a go. Excellent. All right, well, good morning and welcome to our session on transforming chronic care. We're really delighted to have an opportunity to focus on this element of the healthcare system, to bring visibility to the challenges, the benefits, the effectiveness, and what our opportunities are to really improve. I'm Dr. Sherry Lang. I'm the Deputy Chief Medical Officer for the Centers for Medicare and Medicaid Services, and I am a geriatrician and internist, also still volunteer my time serving veterans in the Baltimore VA dementia clinic. So, you know, firsthand, we really understand how challenging it is and so appreciate that each of you has come to this conference today to think about and look for those opportunities to streamline the care processes and refocus the conversations that must be effective between clinicians and the people who we serve. Sometimes we call them patients when they're in our clinic, but really, first and foremost, they're people who need care. So with that, I really want to say my personal thanks to each of our panelists today. And we are joined by, and I'm going to just say the top line of each of our panelists and give them an opportunity to share a little bit more about what they want you, our audience, to know about them. So I'll start with Greg Alexander, Professor of Nursing at Columbia University Presbyterian School of Nursing and a internationally recognized nurse informaticist as well as clinical expert with years of, and we won't say how many years, but years of experience both at the front line and also studying the healthcare system. So what else would you like the audience to know about you, Greg?
Yeah, so I'm a registered nurse professor, like was said. I've conducted research with CMS over a decade and doing a national demonstration project in nursing homes where we looked at payment models, and we also looked at developing HIEs, health information exchanges, within several nursing homes in the Midwest. And I've done research for many years funded by ARC and NIH, looking at quality and how quality is impacted by technology that's implemented in long-term care settings.
Excellent. So really at that point between academics, practice, and technology. So really appreciate your being here. So Nicole Fallon, Vice President of Integrated Services and Managed Care Policy at Leading Age, providing strategic leadership on policy issues relating to aging services. Nicole, what else would you like the audience to know about you?
Well, I always think in healthcare, I've often been told people choose healthcare, and I kind of fell into it by accident, but I am very passionate about integrated care and finding practical solutions to improving how we, interact with the healthcare system. So I've had the opportunity to write our white paper at Leading Age on integration and what we think that should look like, and worked on a variety of models. So I've worked for health plans as well as with our providers who are assisted living, long-term care, home health. If we provide care in your home, out of your home, that's us. And so happy to be here today.
Excellent. So really perspective of meeting people where they are, which was mentioned earlier today. So we also are joined by Allison Reichert, an independent community pharmacy manager with over a decade of experience providing high quality care with a special attention and recognition of the needs of people who are in rural communities. Allison, what else would you like the audience to know about you?
Thank you so much. So I work in a community pharmacy alongside my dad every day. We're very much a mom and pop, father-daughter shop, which, in this world is few and far between anymore. And I think that I have a unique perspective growing up in the pharmacy. Pharmacy's been in my family for over 100 years. And so I think I have a unique perspective of how the pharmacy world has evolved, seeing it from such a young age and such a, frontline view of it. And so I'm excited to be here today to talk about how we can continue to evolve and grow.
Excellent. We're really honored to have you as part of the panel today. Last but certainly not least, we have Dr. Ashby Wolf, family practice physician extraordinaire, and also a chief medical officer responsible for the entire Western Seaboard and the Pacific in her role as a regional chief medical officer. Ashby, what else would you like us to know about you?
Thank you, Sherry. It's a pleasure to be here. And I think in addition to what Sherry mentioned, I've tried to build up expertise in my career here at CMS to really understand what it means to provide care in a rural, a frontier, a geographically isolated community, a tribal community, or an island community, as we do serve our beneficiaries all the way out in the outer Pacific of Guam, American Samoa, and the Northern Mariana Islands. So thinking about the ways in which we provide whole person care and comprehensive care in the digital space is a really interesting conversation there. And I'll just close with saying that I also, as part of my work at CMS, helped to co-lead the Acute Hospital Care at Home initiative, which has its own interesting place in these conversations. So really looking forward to our discussion.
Excellent. And as you all can see, we have not only expertise and depth, but we have an interdisciplinary perspective, which is critical, not only across care settings and the continuity that's needed, but also bringing different perspectives to the care and keeping of the people who we serve. So that is something that's very unique and necessary in the management of people who are living with chronic illness. And often it is not just one illness, right? And that's part of the challenge that we have across CMS, which is, although we are charged with and we have the honor of touching upon the lives of 1 in 3 Americans, the populations that we serve are increasingly complex. Very few people have one condition. So with that in mind, Allison, maybe we can start with you, and you can share what your thoughts are about what are we succeeding at? How are we, what's working? And also then we can start to talk about what remains hard, what's difficult. Allison, to you.
Thank you. So in rural community pharmacies, one of the biggest successes that we see is the accessibility and continuity that pharmacists provide to our patients. So Sherry mentioned that I live in rural Southern Illinois, but let me kind of paint a picture of how rural that is. Where I live and where my pharmacy is, the nearest critical access hospital is 30 miles away, with the nearest larger hospital system being about an hour away. So that includes any kind of specialized care that a patient may need. So with that, the community pharmacy ends up being that front door to healthcare for so many of our patients. And our patients rely on us and they trust us. Because of this, we see our patients frequently. I see so many of my patients on a weekly basis. And so community pharmacists, rural community pharmacists, are perfectly positioned to notice when something goes wrong. So whether it's a COPD patient that's got worsening symptoms and they come in day after day and we notice that cough is getting worse. Or maybe it's a diabetes patient that we've been coaching and their blood sugar levels, their readings are slowly creeping up. Or maybe it's a senior who we notice is having some adherence issues, and on conversation with the patient, we realize it's because they've been experiencing a side effect, and they tell us that information. And so things like that are things that community pharmacists, rural community pharmacists like myself and my colleagues pick up on every day. And these are things that we can communicate to care teams to hopefully provide better outcomes for the patients. So those are our strengths. Ready to go into the weaknesses?
Absolutely.
All right, I could talk about the good stuff all day
Yes,
long, right?
but this audience is here to help to focus in on what can each of us do?
Sure.
What can you all do? So Allison, go ahead.
All right, so the barrier or the breakdown lies in the lack of infrastructure and interoperability that pharmacists have to care teams. Panel 1, Grace, thank you. When you guys started talking about fax machines, I was like, man, they nailed it. Because I got news for you. All those faxes, I can't remember the billions of numbers you said. You know where they come from? Your pharmacy. In community pharmacies, the large percentage of our communication happens via telephone and fax, because that's all we have. And so in rural communities, this is particularly important because this delay can not only be inconvenient to have to say to the patient, hey, I sent them a message, I left them a message, I've called, I sent a fax, I'll call you as soon as I hear, but if you get worse, go to the emergency room. I say that far too often in my practice. And so this delay is not only inconvenient, but it can also lead to worsening. And worsening can lead to ER visits, hospital admissions, and hospital readmissions. And we already know that readmission rates are rising in rural communities. So pharmacists, community pharmacists, stand willing and able to fill in that gap. But the system needs to recognize and integrate our role. I think CMS can play a key role in enhancing interoperability to electronic health records for pharmacists by providing economic incentives for more coordinated care. We know CMS also recognizes pharmacists already as healthcare providers for information blocking purposes. However, for this to change, the conduct of other healthcare providers, healthcare IT developers, networks, and exchanges will not change without disincentives for information blocking. So, I've said so many words, but ironically, I think I can sum it all up with one word, and that word is access. Pharmacists, our strength lies in the access that pharmacists provide to healthcare for our patients. And our weakness lies in the lack of access pharmacists have to interoperable care teams. I think if we can modernize communication and fully integrate pharmacists into care teams, we would see a dramatic improvement in the outcomes of our chronic care management of our rural patients.
Very good. Now, just to build on that perspective, however, so, you mentioned someone with COPD, you mentioned someone also with diabetes. Likely they have both, maybe a third, a fourth. So can you just talk a little bit about what good would look like from your perspective in helping our patients, our beneficiaries, the people who we serve, and the clinicians juggle all of that? Can you say a little bit more about what's needed?
Let's not talk about just good, let's talk about great.
Yes,
Best
I
case
like that.
scenario, right? So where I live, I think, again, painting this picture, it is not uncommon for patients to have prescribers where I live in Southern Illinois in 3, maybe 4 different states. I live in the very southernmost point of Illinois, so a lot of my patients have prescribers in Missouri, Illinois, Kentucky, and sometimes even Tennessee. And unfortunately, the sicker a patient is, the further they must travel for their care. On a personal note, I recently had a family member, a very close family member, travel 3.5 hours one way to see an endocrinologist. That really kind of paints the picture for you. So in a perfect world, pharmacist, we sit at that interoperability juncture, right? So you've got patients managing multiple chronic conditions with prescribers spread out hundreds of miles. And this is what happens in rural communities. So in a perfect world, pharmacists sit at that interoperability juncture. And if integrated into care teams, integrated into EHRs, we would be able to complete a full picture for every prescriber in that patient's care.
Excellent. So Nicole, you actually see the healthcare system from a different perspective, which is care that actually has to meet the needs of people wherever they are. Again, it is in part about infrastructure, but it's about using the infrastructure and access to different infrastructure effectively. So from a systems perspective, especially for long-term services that are needed, what are your thoughts?
So I want to echo what Allison said. I think the message you might take away from today's panel is the models we need to manage chronic care have to go far beyond just physicians and hospitals. There are so many providers that are part of our, we like to call the constellation of care, and I would argue it goes beyond just care. It's social services. It's like the Make America Healthy Again, right? It's nutrition, it's social determinants of health. There's a lot of elements that go into that whole person. In the aging services space, it's funny because I look at all these great models, ACOs, bundled payments, we've participated in some of those. Our members do institutional special needs plans, not just participating, but sometimes leading PACE programs. But I wanted to touch on just a couple of examples today where I think, as somebody who's passionate about integration, we're starting to see some opportunities. And they're small scale, but I think we've got some takeaways from them as well. So first, there is a rural pilot program that's being funded through grant money, because there isn't money for aging services providers typically to do these types of models or tests. It's called Connected Communities. It's in Minnesota. There are 5 pilots right now, and 2 of them we refer to as legacy organizations, because they started this and they built a roadmap so that the next 3, our next round, are using that roadmap to kind of expedite what they're doing. Now, what's different about this pilot program is the aging service provider is serving as kind of the lead, as the backbone of the work being done. And what they're doing in these rural communities is they're coming together, and it's not just the healthcare continuum sitting around a table. So it's the hospitals, it's the tribal agencies, it's the area agencies on aging, but we have community leaders as well. And their first step is really to do assess what are all the things that we're doing. Half the time we don't even know what services are available. Physicians don't know where to refer somebody to because they don't even know what's available. So the first is kind of what do we have? And then based on it, where are the gaps? And it's a little bit, I like to think of it as collaboration versus competition is what we're achieving here by coming together and saying, instead of each one of us trying to build out something to address that gap, what if we spent our money together to do it once, or to do it as many times as we needed to, instead of competing with each other. And the cool thing that they're doing is it's everything from health coaching to embedding care navigators and care coordinators into the primary care and specialist office, who do kind of the pre-assessment around social determinants, and then making sure that care navigator, instead of the poor physician having to do this, plugging them into the community resources. But it goes beyond that too. It's the mental health components. It's getting away from social isolation and getting into more connected, being connected into the community. So older adults not as other, but as part of. And those are just a couple of the things. I could go on forever, but.
This is terrific. And so, Greg, if you would build on some of those observations, from a technology standpoint, not only infrastructure, but different tools, what are you seeing as the biggest opportunities that we have seized thus far? What more can we do?
Well, I think I have to couch this in the different sectors where people live. So most people want to live independently. They want to live in their own home if they can. And we try our best to provide and wrap services around those people that live in the community, but sometimes they need help and they may have to move to an independent living setting. I have a 93-year-old aunt who just moved to an independent living setting with assistance, medications, cooking, activities of daily living last week. So she's been living on her own 93 years, and she's just moved into an assisted living facility, a complete change in her lifestyle, and ours, as a matter of fact. And then, you know, and her whole vision now is trying to stay out of the nursing home, because that's the next step, because she'll probably never go back to where she is independent at home, because she has mild dementia and is a little bit forgetful. And so you have to think about those three settings and separate than acute care, but they all have to work together. So I mentioned that I worked with CMS on a demonstration project, and what we did was, my part of that project was building an HIE and trying to connect nursing homes with long-term, with acute care settings to sort of share the burden of data liquidity, trying to move data across settings. And it really took a village to make that happen. It took a lot of convincing to get the nursing homes to participate. And when the project was over, many of them didn't decide to participate, even though we were there to build that and help them build it for them. You know, I think the whole message that I'm hearing from our first speakers is that it really does take interdisciplinary work. It takes the engineers, it takes nurses, it takes pharmacists, it takes the organizations, it takes the policy people, and we all have to come together like we are today to talk about it and to recognize the possibilities and the limitations and the strengths of the settings that we work in. They're not individual settings. They're all part of the continuum. And we sometimes get in our little boxes and we think about our little setting without thinking about what's happening outside that might be affecting the people that are in that setting that you're in.
So that sounds like both a challenge and an opportunity, right? Because what I hear from your remarks, Greg, is something that may not be addressed in the context of a clinical event or a clinical exchange between clinician and patient, which is, and I heard it a bit this morning in the earlier panel too. Like, can the person in front of you, can they walk, right? And can they provide their own self-care? What is their cognitive ability? You need to be able to think clearly and be able to navigate. So the healthcare system, and even for follow-up or risk non-adherence. It's something that I see in my clinic often. So I think, you know, for those of you who are developing solutions, to be able to understand what those needs are that will be translated across specific diseases. So, and also over time and space, right? Which is all about how do you focus on the needs of the person in front of you to do what they need to do in their everyday lives. And sometimes it is hard, and, you know, having family and also myself experiencing the journey through healthcare, we are not at our best when we're wearing those patient gowns, which are not designed for function, by the way. So that's just part of it, but just saying, I think, you know, we have to help our beneficiaries, we call them patients, when they're in the clinical setting, to be engaging effectively in the care that's provided. So Ashby, you see this challenge and the opportunities from all angles, right? As a family practice physician, but also as someone who is trying to move the system to provide care in in environments and in communities that it can be hard. What are your thoughts? What's CMS working on? What do we need to, what could we do bigger, bolder, faster? And what help do we need from those who are attending as audience members today?
Thanks, Sherry. I think there's been so much that's been said that resonates with me as a practicing family physician, but also as someone who is helping to support the implementation of a lot of different programs and initiatives at CMS. I think one of the most exciting things, and something that resonates with me as I hear each of you speaking, has to do with the access model. And we heard that mentioned quite often during panel 1. But just the acronym ACCESS doesn't necessarily say it all, and I want to highlight it briefly for you all. ACCESS is an acronym that stands for Advancing Chronic Care with Effective Scalable Solutions, and it's a model that was relatively recently announced by our Innovation Center that at its heart is designed to address a particular problem in that many of the opportunities you all have highlighted, we don't have a payment mechanism for that, period. And so the access model is built around the idea that we can test a new payment model or payment structure to address the fact that clinical practice and even patients engaging in their own care look so dramatically different than it did pre-COVID. If we think about what life looked like for each of us accessing care in 2019, for those of us who are clinicians or engaged in helping to provide services, what that looked like in 2019 and what it looks like now. As clinicians, we engage with our patients virtually much more often. Our patients and family members are leveraging digital health technology, wearables, as was pointed out, but clinicians don't have a mechanism to be paid to think through that with the patient. And so access with the outcome-aligned payments process is really designed to provide a recurring payment to clinicians in order to support that care team managing a patient's care. And then that payment is also tied to measurable outcomes so that we're really trying to enable the entire clinical care team to provide care and help a patient manage their chronic conditions outside of the four walls of the office or the clinical space. And that's a really profoundly challenging thing to do. So I think it's worth watching how the access model moves forward. And access is actually focused specifically on supporting our Medicare patients with particular chronic conditions such as diabetes, high blood pressure, depression, chronic pain, things that really challenge our patients in their functional and their day-to-day goals as well. And so I think this will be an opportunity for us to see how we can further engage patients in this space. They'll have more options potentially to manage their care. Clinicians will have opportunities to spend the time to engage with patients, and Original Medicare will have a mechanism to pay for that. So that's one thought I have about where we're going. It's going to be very exciting to watch that happen.
Excellent. Yeah, please, Greg.
You mentioned your discussion made me think a little bit about panel 1's discussion about transparency. I worked on the National Academy of Science report on improving the quality of long-term care, a big report that was released in 2022. And one of the areas that we made big recommendations on was transparency. And it had to do with how long-term care organizations, specifically nursing homes, are utilizing the funds that they receive in order to improve care. And your discussion about the access model and providing incentives to help build better chronic care models makes me think of that transparency, that if we provide funds, and a lot of funds, to organizations to build better chronic care systems, what does that look like? How are they utilizing those funds? There needs to be a level of accountability along with the transparency so that it really is getting to the patient and not, or the people that have the care that we're providing for. So I think it's really important to think about that.
Absolutely.
Please.
Payment really is, in some ways, at least our current structure, a barrier to where we want to go, right? So I hate to say it, but right now, our ACO models reward typically the physicians in the hospitals, not that they don't deserve rewarding, But it's more than the physicians in the hospitals that are part of the care and the outcomes that occur. But part of the reason we get shared savings out of those models is because we're limiting care, like skilled nursing care, because it's a per diem, right? So for every day of service I don't deliver, it's a savings that goes somewhere else. So I think one of the things that's exciting to me that's on the horizon is the ACO lead model, and embedded within it, another acronym, CARA, let's see, CMS administered, I want to say reimbursement something, but see, somebody knows what it is. Risk arrangement, thank you. I feel like we've been asking that for a while, that each one of the providers that are part of the care that's being delivered or the services need to have not only skin in the game in one sense, but referrals aren't enough of a financial incentive to really change the dime. So we have to get out of fee-for-service, which we've been talking about, and into more value-based care across provider types, I think.
So to build on that, let me ask you this question, and this is for each of you. So here is where, when we're thinking about value, right, we've also heard Dr. Oz this morning with the emphasis is on outcomes. So for people living with chronic illnesses, not just one, but many, how do we converge both the policy, the practice, the technologies to enable delineation of what outcomes are meaningful for the people who we serve? Is that a challenge, or is that an opportunity, or both? And I know all of you have thoughts about this. Allison, did you want to start?
Yeah, I think it's both a challenge and an opportunity. And, I think the number one outcome would be the quality of life for the patient, right? Reducing the morbidity that they experience. And so in my practice, I think, there are pharmacy-led interventions that can lead to decreased morbidity for the patients. And so again, to further my point from earlier, I think by integrating pharmacists and other clinicians into care teams, that interdisciplinary model, I think that's how we get there. I think that's how we produce better outcomes. As providers, we simply cannot know what we do not see. But with an interdisciplinary model and, by integrating, like I said, community pharmacists, the ones who see our patients the most frequently, I think we can create a model where we do see more and we do know more and we do share more data to produce better outcomes.
Excellent.
And I'd actually like to build on that, Allison, because I think one of the most profound things you said was that we can't address what we don't see. And my experience with the CMS Acute Hospital Care at Home initiative has actually really touched a chord on me to that exact point. I think when we think about outcomes, one of the things, if any of us have ever been hospitalized or any of our loved ones, or we've provided care for someone who's been hospitalized, one of the biggest outcomes that person has is to get back home and to not come back to the hospital, to avoid a readmission. And I think, when we think about that spectrum of care, there's an excellent paper out of the University of Riverside, was published in 2024, that I thought did a really nice job of summarizing all the different factors that can contribute to increasing someone's risk for readmission. But what the paper also emphasized was that it's the transition from acute space back to the community where there's so much risk if the patient and the family don't understand what the expectations are, or if there's poor communication among the care teams. Things like medication errors, falls that happen when the patient gets back home because of the deconditioning that happens when they're in the hospital. All of those factors that can contribute to someone misapplying their understanding of their discharge instructions, missed follow-up appointments that lead then to a re-exacerbation of their condition. I was speaking with a clinician who's a hospitalist for one of our hospital at home programs, and he was saying that he had this patient who would often come back. He had congestive heart failure, diabetes, high blood pressure, among other things. And this physician would always say, "Oh, he's back. What does this guy not understand about what I tell him when he leaves the hospital?" So now this hospitalist is actually part of the hospital at home care team. This patient gets admitted, gets assessed, and is transferred home for acute inpatient level care in the home setting. And the first thing that the care team does when they're in the home is they do a big home assessment, which of course includes things like checking for fall risk, adjusting what durable medical equipment might facilitate this patient's transfers, and what does the patient have to eat, and how can we support their nutrition. Well, the refrigerator gets opened and there's nothing but the light in there. There's no food in the house whatsoever. And this patient had been too embarrassed to tell his care team on repeated admissions that he lacked access to the right foods to support his care conditions. Well, that light bulb went on in that physician's head, and he said, it profoundly changed the way that I practice. I realized I had been biasing myself for years about what I was telling these patients was clear to them, and it's not. And it also, I realized that I was missing a huge part of their life outside the four walls of the hospital. And so now when I see patients who come back, or patients for the first time, I ask myself, what am I missing about this person's life that is critical to their success outside my hospital? And how can I leverage my care team in order to support that person's goals of care? And I think that's really where there's an opportunity here in terms of interdisciplinary collaboration, and also work to address the person's complexities of life, their dynamics of their day-to-day, what their home life is like, what their family interactions are like. In hospital at home, you can really build that into the care plan during the acute care episode and assess and address plans for discharge in a way that's very, very different. It allows for warm handoffs to the outpatient setting, just as we would think of from one hospitalist service to another. And ultimately, it sets the patient up for more success once they leave the acute care facility. And we're starting to see, in terms of the evidence, that it's reducing avoidable readmissions. And so that's very exciting space, but it really does take a team, and it takes us leveraging both our in-person ability to connect as well as our technology to stay vigilant.
And
one of
also,
the-
please go
One
ahead.
of the
Greg.
points I wrote down as I was thinking about these issues over the last few weeks was integration is relational, and that you really need relationships. You need to build relationships across the entire care team and the person that's receiving the care. They need to be absolutely at the center of those relationships, because they're the ones you're really caring for. They know their environment better than anybody. And so it's super important to build those relationships in order to get better data, to get a more holistic view of a person. And eventually, as systems, healthcare systems that care for these patients, begin to develop those relationships and share what data needs they have, then some commonalities can be achieved. And in our CMS demonstration project, we greatly lowered avoidable hospitalizations because we had team members coming together frequently who met and discussed the problems of the patients that we were having, that we were caring for. And that was the only reason that we really had success, is because of those relationships.
That's an excellent point. And just to also point out, to connect the dots here, so, Ashby, you were speaking of acute hospital home and what happens at the point of discharge. That relational aspect of care, this is an opportunity, since we have both technology-minded expertise here in the room and also clinical service providers. Really, what is the opportunity and challenge is the convergence of the transactional and the relational. Both are necessary, but there has been difficulty traversing those dimensions. So it is a challenge for each of you to think about, how do we enable that convergence? Because really, who's counting on us is the people who we serve. I have one more question for you all. So given that, we have all been hard at work in supporting making America healthy again, and even for the first time, when we think about people living with chronic illness, one might be tempted to think, well, this is chronic disease management. Prevention is over there. How do we actually change that thinking so that we look for every opportunity to prevent not only disease development, but undesired consequences of chronic illness? So just to say it differently, health is not necessarily the absence of disease or diseases. So what thoughts do you have there? Maybe you'd like to start, Nicole.
Sure. So many places to go. We were talking earlier, and I think some of our solutions don't need to be as complex as we make them. So I think my mother had the benefit of having a very close relationship with her primary care doc to the point where she could just text her a question. This is not a virtual visit. This is not a portal you have to navigate to. She just had to say, you know what? I've been taking my Zofran. I'm still really sick and can't eat anything. And she's like, you can take more. And that was all it took. No hospital visit, no, we've avoided that. And that's where I get back to, I think, that care navigator role. So an IDT, an interdisciplinary team, super important, but you've got to have that one person. And I think in chronic care, it needs to be somebody that knows you, that you can just call any question, where I go, how I get there, what have you. And I also think kind of deploying the concept of the hospice model is really important, because it's not only what is my treatment and what is my chronic disease, but what does that care journey look like? Where is my life going to kind of go? How is the disease going to progress and deal with that? And then to your other point about, okay, once we have it, we need to do some management and self-care and all that. But I know our connected communities, one of the things that they've observed is while they're typically focused on older adults, they've started to do the assessment work with community members at 45 to 64. And so you think about Medicare has that annual assessment that you get part of your deal, but do we really access it and do we create a baseline? So having that baseline when you're maybe healthier and then starting to identify those changes from baseline and addressing them earlier.
That's a terrific point. So just to say, from the annual wellness visit, what's required is a personalized prevention plan that can include mitigation of risk of consequences such as adverse drug events, such as falls. So I think there is opportunity. Other aspects to add, Greg, from the prevention standpoint?
Yeah, I'm going to take a little bit of a different approach. I think there's two areas. One, I think it's workforce. I think our workforce in long-term care that deals with, and even acute care to some degree, although I think long-term care has bigger gaps, is just the workforce understand the importance of prevention and how data can be utilized to help them prevent an avoidable hospitalization, as well as how to access team members that are critical to an avoidable hospitalization. And technology plays a big role in that, in the connectivity between those people. In the long-term care setting in nursing homes, for example, an APRN or a medical director oftentimes are outside of the facility. So they have to have a way of contacting them, and oftentimes need ways to be able to show them via telehealth visit what's going on with a person that's in that facility. So they need access and they need training. A lot of the long-term care organizations that I work with that use telehealth don't have good integration of that telehealth visit in the record. So I wonder how in the world some of those things are getting passed on consistently and part of the record that may have really important things about a chronic illness and the management of that illness for that person. So I think I'll stop there. I think that
Can I just add one little thing
please.
there? I think I agree with you that right now there's a lot of, we talk about working to top of license, and I think that's critically important. The data sharing also, I could talk endlessly about that. But one thing I wanted to put out there is the idea of empowerment. So an LPN or even a nurse practitioner doesn't always feel empowered to challenge the cardiologist, the primary care doc, even though they are the one that saw them more recently, observed the change in gait, noticed the breathing becoming more labored, and thinks they need to go to the hospital. We could avoid a lot of hospitalizations through empowerment.
Yeah,
And that's training too.
I want to add on to that because I remembered what I was going to say. I hate it when that happens. One of the things sort of goes back to the first panel is that one of the other notes I jotted down was no algorithm or no technology can replace relational continuity, empathy, trust. You have to have a person there to help understand where a person is in their life. And that impacts all sorts of decisions about prevention, treatment, end-of-life decisions. There's no technology that will help make those decisions and build that level of relationship with people that matter most, the people that we care for. And so, there aren't solutions for that. And that is something that we have to keep in mind as we start implementing AI and implementing these things that seem to think better than we do.
So terrific points, and really to sum this up and reflect on this a bit. So it's about being able to understand what matters most to each individual, who matters most to each individual, and also that is important context of the navigation, of the prioritization of what needs to happen. And so the people who are in those relationships that can be deepened, technology may be able to assist that to be more effective. So Allison, you're also nodding in fervent agreement. What are your
I'm
thoughts?
sitting here chomping at the bit. So you guys have both nailed it for me. So, we talk about having that one person that a patient can come to, that one person that they can text or call and get an answer. And you talked about having, interdisciplinary and having, sharing technology and using that to our advantage. And so I'm sitting over here like, guys, that is what your community pharmacist is. Your community pharmacist, especially in rural areas, is that one person for our patients because simply we don't have the other resources. And I say this all the time, and I mean it so much, it is of no fault to the providers that we do have. There's just simply not enough of them in rural communities. And so rural community pharmacists become that touch point for our patients. And so I think it is, it only makes sense to integrate pharmacists into care teams, to increase interoperability so that we're able to communicate, not just via fax. So we're really able to communicate and create clear pictures for all of the providers in the patient's care team.
Excellent.
And just to add one other piece to this conversation, because each of you has mentioned integration in a different way, which I think are all equally important. But there's also something, Sherry, that you said that struck a chord with me, which is we think about chronic disease management, we think about prevention kind of over here. Too often, we also think about kind of behavioral or mental health in its own bucket, as opposed to actually pulling it into chronic disease management and at times prevention as well. And so I think about the way that CMS has sort of been having an ongoing conversation, soliciting public feedback, engaging with the clinician and the patient community about ways that we can actually improve our own payment policy as it comes down to payment, to really support the integration of behavioral health, psychiatric coordination, and those kinds of models where we see truly integrated care. And CMS is moving in that direction slowly but surely with some of our payment policies this year that support the integration of psychiatric and collaborative models of care into our advanced primary care management codes. But I think as we continue this journey and this discussion, always keeping that in mind, that behavioral health very much needs to have a seat at the table, as it is so fundamental to our own health, to say nothing of our clinical health, as our own health on a day-to-day basis. So just wanted to add that piece there.
Oh, so important. This is about whole person care, right? So how do we enable and look for, identify those technologies that help us to really connect around the people who we serve? So last question for you. This is lightning round. Our time is coming to a close. So I'll go right down the line. Question for each of you in one sentence, or maybe two. What are you most excited about over looking ahead at the next 12 months? Greg, what comes to mind?
Good, I get to go first.
Yeah.
Well, there's all sorts of new innovations, AI for one, and I was reading papers about AI in long-term care on the way here yesterday on the train, and there's so much potential in that space for clinicians to be able to utilize it in a way that's effective for the people that they serve. But there's a lot of caution. A lot of caution should be had and taken as those new innovations are developed and created. And so I'm excited to see where it goes, but I'm also a little nervous about it from a clinical standpoint.
Okay, fair enough. Nicole?
Oh my goodness. I'm going to pass for right now.
Okay, we'll
I'm still
come back to you.
processing.
Yes,
Yes,
Allison.
so for me, it seems like now more than ever, there is more momentum at including other clinicians like pharmacists into interdisciplinary care teams and interoperable care teams. And so I'm excited to see where we could go once clinicians like pharmacists are empowered and enabled to act at the top of their licensure.
Excellent. Ashby?
And sort of getting back to basics, I'm excited to watch how our use of the basic telehealth policies that we now have renewed and can continue to use. I'm excited to watch to see where that takes us in the next 12 months. We've learned so much from our experience in the COVID public health emergency. We've learned a lot post-pandemic. I'm excited to see what we can learn from our clinicians and our patients in that space.
Excellent. Okay, it's back to you, Nicole.
Well, I said payment was a concern, and it's a barrier to really integration and success. And I think there's a lot of things on the horizon that create some opportunities around value-based care. And I think there's opportunities for more providers to participate in those value-based arrangements within ACOs, managed care, et cetera, because of some of the new models and new opportunities. So I'm excited to see how that goes.
Excellent. Well, thank you as a panel and each of you for the work that you do and for spending the time and sharing your thoughts with us. I think each of us you've given us a lot to think about and also to be hopeful about for the next 12 months, for the next few years. So thank you for each of you who is part of our audience. I believe we have a 10-minute break that when we come back, we really are looking forward to Patrick Newbold and his session that he is leading, our Chief Information Officer and also the Director of the Office for Information Technology. So with that, thank you for joining us, and we'll be back.